a loss of adhesion between cells within the epidermis, called acantholysis, edema between epidermal cells, called spongiosis, and dissociation between the epidermis and dermis. Blisters that form within the epidermis tend to be more fragile than subepidermal blisters. Blisters that are smaller than 1 centimeter in diameter are called vesicles, while blisters that are larger than 1 centimeter in size are called bulla. There are various causes for blistering disorders, including autoimmune disorders, drug reactions, infections, genetic disorders, and traumatic injury. These conditions range from benign to life-threatening conditions. Life-threatening cutaneous blistering disorders include toxic epidermal necrolysis, staphylococcal scalded skin syndrome, disseminated herpes simplex virus infection, and disseminated herpes zoster. Broadly speaking, blistering skin disorders may be divided into generalized or localized disorders. Among generalized blisters, some cause systemic illness, whereas others don't. Generalized blistering disorders that are not usually associated with systemic illness include malaria crystallina, bullous impetigo, linear IgA bullous dermatosis, epidermolysis bullosa, pemphigus, pemphigoid, and dermatitis herpetiformis. Malaria crystallina typically results in multiple tiny vesicles on the face and trunk due to obstruction of eccrine sweat gland ducts in the setting of excessive warmth. Usually, the rash of malaria resolves on its own. The key is to avoid overheating the body by wearing lighter clothing, staying hydrated, and keeping a cool environment, for instance by using an air conditioner. A soothing ointment like calamine lotion can also help. Bullous impetigo is caused by Staphylococcus aureus, which produces exfoliative toxins that cleave adhesions between the epidermis and dermis, leading to the formation of bulla. The cleavage plane is either subcorneal or within the upper stratum granulosum. The bulla rupture easily, leaving erosions. The most frequent areas involved are the face, trunk, perineum, and extremities. Since Staphylococcus aureus are found on the skin and can be spread among family members, prevention is targeted toward preventing transfer from person to person. Bullous impetigo can be treated with oral antibiotics, like cephalexin, and if it doesn't improve, it could indicate that it's due to a MRSA infection, which may require vancomycin or clindamycin. Bullous impetigo in newborns, children, or adults who are immunocompromised can develop into a more severe and generalized form called staphylococcal scalded skin syndrome, which typically causes systemic symptoms like fever and malaise. The mainstay of treatment is supportive care with rehydration and antipyretics, like ibuprofen or acetaminophen, as well as IV antibiotics, initially giving penicillinase-resistant penicillin, such as nafcillin or oxacillin, while vancomycin should be considered in areas with a high prevalence of MRSA or for individuals who failed to respond to initial therapy. Linear IgA bullous dermatosis is a subepidermal autoimmune disorder associated with the deposition of IgA at the basement membrane zone of skin and mucosal tissues. The cutaneous bulla often have a distinctive grouped appearance that resemble a cluster of jewels, while mucosal lesions primarily present as erosions or ulcers. This disorder may be idiopathic or drug-induced. Some drug classes that cause this include antibiotics like vancomycin, antihypertensives, and NSAIDs. Drug-induced linear IgA bullous dermatosis often resolves after stopping the causative drug. On the other hand, idiopathic cases may persist for a decade or longer, and thus systemic therapy with dapsone is generally required until the individual shows clinical remission with gradual tapering toward treatment cessation. Epidermolysis bullosa is a rare blistering disorder that may affect both skin and mucous membranes. Now, healthy individuals have protein anchors between the epidermis and the dermis to prevent the two layers from moving independently from one another, causing shearing. In people with epidermolysis bullosa, the two skin layers lack the protein anchors that hold them together, resulting in extremely fragile skin. That's why any kind of trauma, even minor mechanical friction like rubbing or pressure, will separate the layers of skin and form blisters and painful sores. Epidermolysis bullosa may be genetic, called congenital epidermolysis bullosa, in which individuals affected present mutations, or it can be acquired, called epidermolysis bullosa acquisita, in which individuals affected present antibodies against type 7 collagen. There is no cure for epidermolysis bullosa. Management involves wound care, pain control, controlling infections, nutritional support, and prevention and treatment of complications. Pemphigus is a rare group of blistering autoimmune diseases that affect the skin and mucous membranes. Now, in healthy individuals, a protein called desmoglein attaches adjacent epidermal cells via attachment points called desmosomes. In pemphigus, autoantibodies form against desmoglein, so the epidermal cells become separated from each other, a phenomenon called acantholysis. This causes blisters that slough off and turn into sores. There are several types of pemphigus which vary in severity. The most common form is called pemphigus vulgaris, and it's characterized by the formation of bulla in the skin and mucosa that quickly evolve into painful erosions, making it hard for these individuals to eat. A positive Nikolsky sign is indicative of the disease, in which there is induction of blistering in normal skin or at the edge of a blister when applying pressure. This occurs because the friction on the skin causes detachment of skin layers, since cell-to-cell adhesions are very weak and fragile. Then there's IgA pemphigus, which is the only pemphigus subtype that's mediated by IgA antibodies instead of IgGs. IgA pemphigus is characterized by the subacute development of vesicles that evolve into pustules and may be accompanied by erythematous plaques. The trunk and proximal extremities are common sites for involvement, while mucous membranes are generally spared. Next, there's pemphigus polyaceus, which is the mildest form of pemphigus, since typically the skin lesions that develop are superficial. They present as small, scattered superficial blisters that rapidly evolve into scaly, crusted erosions and are much less painful. Also, there's no mucosal involvement. And finally, the most severe form of pemphigus is paraneoplastic pemphigus, which is caused by an underlying cancer, especially hematological malignancies. Paraneoplastic pemphigus resembles the vulgaris type, and it's characterized by painful erythematous macules, papules, blisters, and erosions involving the skin and mucosa. There can also be conjunctival involvement, and that can lead to blindness. If not treated, pemphigus can be fatal, usually from an opportunistic infection of the lesions. Broadly, the aim is to decrease blister formation, promote healing of blisters and erosions, and determine the minimal dose of medication necessary to control the disease process. Usually, oral steroids, especially prednisone, are given in high doses. Immunosuppressive agents like azathioprine, mycophenolate, mofetil, cyclophosphamide, IVIG, or rituximab may be used as adjuvant therapy as well for individuals that don't respond to steroids. With paraneoplastic pemphigus, management of the underlying cancer is often the only effective treatment. Moving on. Pemphigoid is a subepidermal blistering disorder that is similar in general appearance to pemphigus, but a key difference is that pemphigoid does not feature acantholysis. The autoantibodies bind to hemidesmosomes and cause complement deposition and inflammation, leading to keratinocyte death and formation of blisters. Pemphigoid is the most common autoimmune blistering disorder, and the most common type is called bullous pemphigoid. Classic skin lesions are urticarial plaques and tense bulla on the trunk and extremities. Intense pruritus is common, and lesions typically do not scar. Bullous pemphigoid may also develop mucosal involvement. The treatment is the same as for pemphigus. Pemphigoid gestationis is another type of pemphigoid that occurs during pregnancy or in the immediate postpartum period. Urticarial plaques and vesicles typically begin around the umbilicus prior to spreading elsewhere with large bulla formation. Treatment essentially is the same, but some immunosuppressants like cyclophosphamide and methotrexate aren't used because they're teratogenic. Ultimately, the most effective treatment is delivery of the baby. Dermatitis herpetiformis is a cutaneous manifestation of gluten sensitivity. This sensitivity leads to the formation of IgA antibodies to gluten tissue transglutaminases found in the gut, and these can then cross-react with epidermal transglutaminases. This causes deposition of IgA transglutaminase complexes in the papillary dermis, which triggers the formation of vesicles and papules on the extensor aspect of extremities, scalp, and buttocks. The lesions are intensely pruritic, leading to erosions and excoriations. The only treatment is a gluten-free diet, which often leads to resolution of these skin lesions over months to years. In addition, dapsone is an effective initial treatment in most people, resulting in the resolution of active skin lesions within days of the start of therapy. Topical corticosteroids may be given in conjunction with dapsone to help alleviate the itching. After 2 to 3 months on a gluten-free diet, the dosage of dapsone is often tapered as tolerated. Now, generalized blisters may also be associated with systemic illness. This includes paraneoplastic pemphigus and staphylococcal scalded skin syndrome, as well as Stevens-Johnson syndrome and toxic epidermal necrolysis, disseminated varicella zoster infection, and disseminated herpes simplex virus infection. Stevens-Johnson syndrome and toxic epidermal necrolysis, or TEN, are severe skin reactions characterized by epidermal sloughing of the skin and mucous membranes. These conditions most commonly occur as a result of exposure to an inciting medication, such as lamotrigine, carbamazepine, allopurinol, sulfonamide antibiotics, and nevirapine. Individuals develop a brief prodromal period of fever and flu-like symptoms, followed by painful erythematous and purpuric macules or areas of diffuse macular erythema that progress to vesicles, bulla, and skin sloughing due to epidermal-dermal separation and full-thickness epidermal necrosis. Complications include dehydration, pneumonia, and sepsis. These two diseases form a spectrum of disease, where the extent of body surface area involvement differentiates Stevens-Johnson syndrome from TEN, being respectively less than 10% and more than 30%, with a gradient of disease between those two extremes in between. These are life-threatening dermatological emergencies. The primary treatment is discontinuation of the inciting medication, followed by management in a burn unit or intensive care unit, and giving IV fluids and parenteral nutrition. Varicella zoster virus infection may cause generalized blistering as well. Varicella zoster virus is one of the herpes viruses, and it causes two diseases. Primary infection causes varicella or chickenpox, a highly contagious disease that most frequently occurs in children with a prodrome of fever and malaise, followed by the development of a generalized eruption of small, itchy, intraepidermal or subepidermal vesicles and pustules surrounded by erythema. Within 1 to 2 days, these lesions begin to crust over and form scabs. Over time, when the adaptive immune reaction kicks in, most of the viruses in the body are eliminated, but some can remain dormant in ganglions for many years. Usually, the virus establishes a latent state within the dorsal ganglia and the trigeminal ganglia. Later on, if the immune system weakens due to aging, stress, or immunosuppressive therapy, the virus can be reactivated. It then travels back up to the skin and causes an infection in the innervated dermatome. That's called herpes zoster or shingles. In shingles, there's typically pain, itching, or tingling in the area where the rash will develop. The rash is usually in a single stripe of painful vesicles around either the left or right side of the body or on one side of the face, along with one or a few dermatomes. It usually takes 4 weeks for the rash to disappear, but the pain can linger for more than 90 days, called postherpetic neuralgia. In immunocompromised patients, disseminated lesions may occur, in which the lesions are not restricted to a dermatome. Chickenpox treatment mainly includes the use of topical antipyretic medications to help reduce the itching. Also, analgesics and anti-inflammatory medications can help reduce the fever. In immunocompromised individuals, antivirals like acyclovir, famciclovir, and valacyclovir can be used. In some situations, varicella zoster immune globulin, or VZIG, which are anti-varicella antibodies, can be given to treat immunocompromised or pregnant individuals. Finally, varicella vaccine can be used to prevent chickenpox by helping the body mount protective immunity against a weakened form of the virus. Similarly, zoster vaccine can be used to reduce the risk of developing shingles. People with mild to moderate pain can be treated with over-the-counter pain medications. Occasionally, severe pain may require an opioid medication, such as morphine. Antiviral drugs like acyclovir, famciclovir, and valacyclovir can be used to reduce the severity and duration of shingles, as well as for prevention in high-risk individuals like in HIV. Now, if a person has localized distribution of blisters, the next step is recognizing their main body location. Most cases of shingles actually present localized dermatomal distribution rather than generalized distribution, as well as herpes simplex virus infection. Most of the time, when herpes simplex virus or HSV infects a person, there are no symptoms. Once in a while, though, it can cause a localized eruption composed of grouped, small, often umbilicated vesicles or pustules. The lips, genitals, and buttocks are common sites of involvement. Primary infections tend to be most severe and can be accompanied by lymphadenopathy and flu-like symptoms. Also here, disseminated herpes simplex virus may develop in immunocompromised patients and patients with a compromised skin barrier, such as those with atopic dermatitis. The term eczema herpeticum is used to describe when this develops in people with atopic dermatitis. In some disorders, blisters develop in dependent areas of the body, where there's maximal pressure. Bullous disease of diabetes, also known as bullosis diabeticorum, is a rare cutaneous complication of diabetes mellitus, in which there's the spontaneous development of non-inflammatory, painless subepidermal bulla, most often on the feet or lower legs. The bulla spontaneously resolve over the course of a few weeks, so specific treatment is unnecessary, unless there's secondary infection, in which case they're treated with antibiotics. Localized blistering in dependent areas may also occur in comatose individuals in the setting of loss of consciousness, like in barbiturate overdoses and neurological disorders. Coma blisters are tense, subepidermal bulla, sometimes preceded by erythematous or ecchymotic patches or plaques. The blisters spontaneously resolve within a few weeks. A fairly common condition presenting as localized blistering are friction blisters, which are intraepidermal blisters that may occur at sites of pressure and friction. They most frequently occur on the heels and soles of the feet due to friction from shoes due to walking or running. Other localized blistering disorders that present in hands or feet include dishydrosis and erythema multiforme. Dishydrosis, also known as acute palmoplantar eczema, presents as intensely pruritic intraepidermal vesicles on the palms, soles, and sides of the digits. The cause is unknown, but triggers include allergens and frequent hand washing. Treatment is generally with topical corticosteroids, and antihistamines may be used to help with the itching. In erythema multiforme, the classic rash is with target lesions, in which there's a central subepidermal vesicle surrounded by an often hemorrhagic maculopapula. Lesions usually affect the extremities and mucosa, and it commonly occurs along with a herpes simplex virus infection. Erythema multiforme is frequently self-limiting and requires no treatment. Contact dermatitis is another condition that may present with localized blistering, usually in a linear distribution of intraepidermal bulla and an itchy burning rash where there's skin contact with a foreign substance like nickel or poison ivy. The key treatment step is identifying, removing, and avoiding the triggering substance, as well as washing the involved skin area with mild soap and cool water right away. If blistering develops, cold, moist compresses applied for 30 minutes, 3 times a day can offer relief. Emollients are moisturizing treatments applied to help manage dry or scaly skin. In addition, topical corticosteroids may be applied to help soothe the skin rash, while oral corticosteroids may be taken in case of a severe episode of contact dermatitis and it covers a large skin area. Antihistamines may be used to help with the itching. Now, for diagnosis. A history and physical can be followed up with a skin biopsy, serologic studies, and microbiologic tests. A skin biopsy with light microscopy can reveal the skin layer involved in blister formation and the type of inflammatory cell infiltrate. If it's a small vesicle, then the entire lesion should be removed. For larger lesions, a specimen should be obtained from the edge of a blister, and it should contain both portions of the blister and intact skin. Direct immunofluorescence studies are typically done when an autoimmune blistering disorder is suspected, because they can detect the antibody or complement deposition pattern and skin level of involvement. For example, in pemphigus vulgaris and pemphigus foliaceus, there's intercellular antibody deposition in the epidermis, whereas in bullous pemphigoid, there's linear antibody deposition along the basement membrane. Finally, it's important to take a biopsy from normal-appearing skin adjacent to the blister, also called a perilesional biopsy, to get reliable results. Also, serologic testing may be useful for the evaluation of autoimmune blistering disorders, using indirect immunofluorescence to detect antibodies within the circulation. If the target of circulating antibodies associated with specific autoimmune blistering diseases is known, antigen-specific testing can be used, such as ELISA, immunoblotting, and immunochemistry. Finally, if infection is suspected, microbiological tests can be useful for diagnosis. The diagnosis of bullous impetigo and staphylococcal scalded skin syndrome may be aided by a bacterial culture of the blister site. In individuals with suspected herpes simplex virus or varicella-zoster virus infection, studies such as Sank smear, viral culture, polymerase chain reaction, and direct fluorescent antibody testing may be used to confirm a diagnosis. All right, as a quick recap, blistering skin disorders are characterized by the presence of blisters, which can be classified as vesicles when smaller than 1 centimeter and bulla when larger. Generalized blistering disorders that are not necessarily associated with systemic illness include malaria crystallina, bullous impetigo, linear IgA bullous dermatosis, epidermolysis bullosa, pemphigus, pemphigoid, and dermatitis herpetiformis. On the other hand, generalized blisters associated with systemic illness include paraneoplastic pemphigus, staphylococcal scalded skin syndrome, Stevens-Johnson syndrome, toxic epidermal necrolysis, disseminated varicella-zoster infection, presenting as varicella with primary infection and shingles with reactivation, and disseminated herpes simplex virus infection. Now, if a person has localized distribution of blisters, the next step is recognizing their main body location. Most cases of shingles and herpes simplex virus infection actually present localized dermatomal distribution rather than generalized distribution. Some disorders may favor the development of blisters in dependent areas of the body, such as bullous disease of diabetes and coma blisters. A fairly common condition presenting as localized blistering are friction blisters on the heels and soles of the feet due to friction from shoes during walking or running. Other localized blistering disorders that present in hands or feet include dishydrosis and erythema multiforme. Finally, linear distribution may be observed in individuals with contact dermatitis. For diagnosis, a history and physical exam can help identify the likely cause, but follow-up tests include a skin biopsy, serologic studies, and microbiologic tests.